congratulating you for setting up this platform and also for a wonderful presentation you gave yesterday in a provincial Zoom meeting regarding the use of chloroquine in COVID-19 patients. If you can please maybe make it available to those who could not attend, we would really appreciate it. Today I'll be talking about the approach to caring for a COVID-19 exposed healthcare worker in a hospital setting. The outline of the topic will be talking about the principles of infection prevention and risk reduction, reporting, quarantine, isolation, contact and contact tracing, testing criteria, PUI patients under investigation, de-isolation criteria, which I think it forms the most integral part of this presentation, as well as the decontamination procedure. The purpose of this is to review important intervention in the care and the management of healthcare workers exposed to COVID-19. And as you all know, a physically and a mentally healthy, well-equipped healthcare workforce is vital for the country's ability to manage COVID-19 cases effectively. So we need to be at par with the guidelines. We need to be fresh. We need to be ready as frontliners. So throughout this presentation, we'll be looking on how to take care of ourselves, and if we are exposed, what are the processes that we need to follow. Risk reduction plays a very...
May you make your screen full screen? Your presentation. Slideshow, click on that green arrow, slideshow, yes, below. Yes, that green button, yes.
Is it better?
No. Can you take your mouse cursor to the right lower corner? Lower corner, yeah. There should be a sign that looks like a presentation there. You click on it.
Mm-hmm. I think this piece is diseased. People can't see.
It's left lower corner. Left lower corner.
Slideshow again. The green
left lower corner.
Hope it doesn't go. It doesn't go.
Yeah, start. No. Okay.
No, Lesejo, it's left lower corner.
I think if people can see, let's leave it before it crashes, because now the mic is off.
Okay, there's one last point. On the menus there's a review, there's slideshow. Do you see the pink menus there on top? Yeah, there. Go to your right.
Right.
To your right. You are too fast. There's review, slideshow.
Review.
Slideshow. Yeah, next to review.
Yeah.
To your left, next to review. Yes, slideshow. And
yes.
Then, you don't have the option for slideshow.
There is at the bottom here.
Yeah, click on mirror show. Mirror show. Yes, that. Okay, no, it's okay. I think continue as is. Yeah, it's one of those days. Thanks to Bola.
All right, thank you. Sorry about that. So as I was saying, risk reduction, I think, plays a very critical role in helping us not to get infected. As we have seen in the past 2 weeks, it was on the news. 6 doctors in Gauteng who has passed on within a week. That's not a good sign for us. And also an outbreak in Tampa Hospital with 68 nurses infected in about 2 weeks. That's not good. So we hope this platform and this kind of discussion will create an awareness so that we can learn properly how to protect ourselves. So there are principles, of course, that we use in line in protecting ourselves from this COVID-19. So principles of leadership and coordination and communication that will confront and communicate leadership to provide a safe as possible workspace. Principle of supervision and enforcement of universal COVID-19 precaution that will help in reducing the risk of respiratory transmission. The universal precaution of wearing a mask, physical distancing, and hand hygiene. We need to adhere to that. And then aggressive sterilization, viral particle load reduction within facilities. That can be achieved by improving a facility level ventilation in preventive measures. Screening, self and active, and also testing play a very pivotal role in medical surveillance of our healthcare professionals. We need to adhere to those things. Principle of institutional management of healthcare workers, daily briefing, education, revision of SOPs, supervision, safety and psychological support also play a very pivotal role in healthcare workers in this pandemic. The principle of individual level measure for healthcare workers so that we do not place colleagues and family at risk by not adhering to contact exposure and the NICD guidelines. Management of patients, all patients, visitors must be screened, must be given masks, and must be required to maintain social distancing. The principle of adequacy of control and infection management of practices. So you know that COVID-19 is an unforgiving and effective management require honesty and transparency about IPC gaps and PPE availability. So we hope through our discussions we can see the gaps and discuss issues that we can address to protect ourselves. So if you are a healthcare worker who's been exposed or you are a confirmed case, there are steps that you need to follow. So first, it's your responsibility to report to your occupational health, a nurse or a doctor, and to your supervisor immediately. And then an incident report needs to be written by you, indicating what happened, what transpired, how were you exposed, or how did you end up becoming positive? Was it an issue of lack of PPE, or was it an issue of you were performing an aerosol demonstrating procedure and then you end up being exposed? While you are there, you need to make sure that the first, progress, and final medical reports are being filled up. In a case where you're reporting a positive case, obviously you cannot be there. So now most of these things that I've mentioned above will be done telephonically or through emails. And however, of important, you need to submit a copy of your consent positive result in a case of in a situation where you are a positive case. Then the responsibility of the occupational health doctor or a nurse is to assess if you are exposed, not confirmed, is to assess if you meet a criteria for patient after investigation, and then advise on quarantine or isolation procedures, and that we'll discuss it later. And then if you are a confirmed case, the occupational health nurse or a doctor, they will have to report it to Infection Prevention and Control, CDC and ICD. Those are the ones that are mainly responsible for contact tracing. And from the employer's point of view, their responsibility is to report your case for compensation to the Compensation Commissioner, as well as a compensation of occupational disease and injuries. And then it's their prerogative to grant you an occupational sick leave with full pay. I must say there's quite a lot of documentation that you need to fill while you're at occupational health service or upon return from your quarantine. Dr. Zwan will give us a brief overview later in the discussion. So, time and again, what we get to be challenged with is contact. If one of the nurses or one of the doctors tests positive in a hospital environment, as you all know, if you get a hoo-ha where everyone says we are a contact, we need to follow guidelines so that we don't lose the plot and be able to manage this disease. So a contact is being defined as a healthcare worker providing direct care for a COVID-19 or exposed to a COVID-19 patient while not wearing, I want to repeat, while not wearing recommended PPE such as gown, gloves, N95 eye protection. If everyone says they are a contact, they should not be wearing this. Otherwise, everyone will be a contact and then we'll have to test everyone. So we need to adhere to these guidelines and these definitions so that we can be able to help each other. It's been further subclassified into high risk and low risk, a definition of a contact. A high risk, it's somebody who's being, a healthcare worker who's being exposed to a confirmed case that are within 1 meter of a distance and spending more than 15 minutes with the case, not wearing full PPE or wearing PPE that has failed or poorly worn PPE or having direct contact with respiratory situation. Whereas a low risk is the opposite. It's exposure to a confirmed case, but you were 1 meter away with spending less than 15 minutes with the patient, and confirmed in this case at that time it was wearing a physical mask. We need to understand this terminology so that when we're going to discuss the isolation and the quarantine procedures, we'll be referring to high risk and low risk. So now, who gets to be tested? So most of you could be worried now, saying that, okay, if I'm a healthcare professional and being exposed, when can I be tested? Or what criteria do I need to fit in to be tested? So usually at the occupational health center, you'll be tested if you are a healthcare worker who's a contact and having symptoms suggestive of COVID-19 disease. Or if you pass the screening tool, as you know, all healthcare workers in the morning, you screen at your workstation. If you pass the screening tool with a score of 10 or more, you are eligible to be tested. Or if you spend more than 15 minutes contact time or in the same vicinity with a healthcare worker or a colleague who tests positive later. These situations are unavoidable. We experience them every day at our workplace. We still have people sharing kitchen in theater or in the wards, people sharing a drink, lift clubs. It's very rare to find people wearing masks in a car or even sharing a cigarette. And I want to discourage this kind of behavior because it's the one that increase the risk and positivity cases in our healthcare professional. However, of importance is that any asymptomatic, whether high or low risk contact, should not be tested. We'll discuss it later why I'm saying this. So now we've got isolation and quarantine. Since we'll be talking about de-isolation and de-quarantine, I think it's also important to understand what does these two terms mean. Quarantine usually refers to somebody who's a close contact. A close contact with somebody who has been infected before or who has been traveling to a high-risk area. But in our case, this does not apply much. Quarantine we usually apply to a symptomatic person requiring testing or who has been tested. Whereas isolation, serving the same purpose as quarantine, it's usually for healthcare workers who have confirmed positive results. So we use this term isolation when we've got confirmed positive results, whereas we use quarantine when we are still awaiting for the results. So upon arrival at occupational health, if you are exposed or you are confirmed positive, you will be offered either to isolate or quarantine. If you are confirmed, it's isolation. If you are unconfirmed and tested, it's quarantine. Where can you quarantine? It's either at home, what we call self-quarantine or self-isolation, or in designated area that your NICD and CDC will guide you, either in a hotel, lodge, or B&B. In a case of moderate to severe disease, you may require hospitalization. So we need to understand these terms. What do I mean when I say self-isolation or self-quarantine? Meaning that you'll be eligible to stay at home, you're not going to go to work, not going to school, not going to social events, parties and funerals. You should not use any public transport. Avoid contact at all costs because we want to keep the spread, remember. Have your own bathroom, use a separate room if possible, and avoid shared space such as kitchens and all those. And then your room is said to be that it must be well ventilated. So if you fit in this criteria or you can be able to have the things that I've discussed, then you are eligible to go and self-isolate. Failure to do that, designated areas should be organized, such as lodges and hotels. Or unless if you are severely ill, then you'll need to be admitted. So now following quarantine, you may need to come back to work, or during quarantine, what are the things that needs to be done? So at occupational health, we usually get three types of patients or three types of scenarios. You get a contact worker with symptoms. So now you need to assess if those symptoms, the person qualified to be a PUI, patient under investigation. If the patient qualified to be a PUI, then you'll have to test the patient or you have to test the staff member. And if the results are positive, you follow the isolation criteria, which I'll discuss later. If the results are negative, the healthcare worker has to return to work, but following IPC measures, wearing a mask, washing hands and sanitization, and keeping social distance. In a case if the healthcare worker is assessed not to be a PUI, the healthcare worker will be provided a normal signal. This is a situation where a healthcare worker is a contact but comes with non-COVID symptoms, leg pain, abdominal pain, and things like that. Then in scenario number 2, you may have a high-risk contact. Remember, we defined what is a high risk. So now high-risk contact that is asymptomatic. What do we do with those cases? So if you are a high-risk contact that is asymptomatic, you remember we discussed a definition of a high-risk contact. So now in this case, you have that high-risk contact but you do not have symptoms. What happens? You will be offered to quarantine at home, and then you have to return to work after 7 days, but continue self-check for 14 days. While continuing self-check for 14 days, you need to adhere to IPC precautions, wearing a mask and social distancing, hands washing or sanitizing. And then also you can be a low-risk contact without symptoms. In case of a low-risk contact, as we have defined, you'll be allowed to continue to work, but you must wear surgical mask at all costs, and then you monitor your symptoms for 14 days while at work. During these 14 days, whether you are a high risk or a low risk, should you develop symptoms, then you will have to be tested. So hence you need to continue screening yourself on daily basis. Should there be any healthcare worker who need to return to work before time, any return of work, especially in a case of a high-risk contact, that healthcare worker must provide a negative PCR result on day 5 or should not have any symptoms. I hope this was clear. These are the challenges that we face at occupational health, everyone wanting to be tested. And I think, colleagues, if anything you have to take from this presentation, it has to be this slide. Especially if they are managers, everyone will think that they are contact once somebody tests positive. And if you educate on this slide, like we have said in the principles, one of the principles is to educate every day. So this will be the slide that you need to read in the morning to your staff. So coming to the isolation, remember the quarantine is for unconfirmed cases. It means we're still waiting for the results. We haven't got the positive result. So we use this term, de-quarantine. But when we talk about the isolation, we talk about somebody who has been a confirmed case. So colleagues, I see people using these terms interchangeably. Let's use them correctly to avoid confusion. As you all know, it has been reduced from 14 days to 10 days due to a strong evidence that most cases remain mild disease. And then also, there is no need to repeat PCR if opposed 10 days of the isolation, because it does not necessarily mean that you are infectious. This is based on the studies that were done, IPC guidelines and WHO. So now the de-isolation criteria, the new one is from 14 days to 10 days. It says if you are a symptomatic patient, say maybe you are a contact, and then we test you, and then you become positive. You isolate for 10 days after the initial positive test result. If you are diseased already, having mild disease, you isolate for 10 days after symptoms, after onset of symptoms. In a severe case where maybe you've also been hospitalized, you isolate for 10 days after clinical stability or after being discharged from the hospital. This is another slide that we need to read out every morning to our staff. Of importance is that post de-isolation or even during de-isolation criteria, you still need to adhere to IPC precautions. Daily screening, monitoring, wearing masks, physical distancing, regular hand washing, and sanitization. There are a couple of scenarios that we always face at occupational health. I'll go through them, just a few of them. Scenario 1 is the one that I've actually just discussed, where a healthcare worker will call and say that I'm positive or will test positive. That healthcare worker will need to be placed on a sick leave, and then the area that the healthcare worker has been working will need to be decontaminated or disinfected. We'll discuss that later in the presentation. And then in a case like I've said, it needs to be reported to NICD, where they can be able to do contact tracing and also report your case to labor and compensation. Then you'll have to go and self-isolate at home if you can be fit the criteria for self-isolation. Otherwise, if you've got symptoms, you may need to be admitted. So like I said, it's 10 days after your initial symptoms, and then it's 10 days de-isolation after discharge or clinical stability has been maintained. In a case 2, you may have a co-worker with symptoms suggestive of COVID. So that co-worker, either through screening or just coming to work in the report, such kind of symptoms. So that care worker, you need to assess, you need to be assessed by a professional body, either a doctor or a nurse. If the patient fit criteria for PEI, then they'll have to be tested. If the results come back positive, scenario 1 is followed. If the results come back negative, you have to come back to work. Okay. If the healthcare worker does not fit the criteria for PUI, then the usual or the normal sick leave procedures are followed. In the case of scenario 3, high risk contact to a confirmed case, like I said before, you will be allowed to go home for 7 days to quarantine, and then after 7 days you return to work. You monitor your symptoms for 14 days. If anything happens between these days, from day 1 to day 14, say you develop symptoms, you're eligible to go and do testing. If you wish to return to work early, you need to provide PCR negative results on day 5. In scenario 4, it's almost the same as scenario 3, but in this case, you are a low-risk contact. Remember, we defined what is a high risk and a low risk. In this case, you will be allowed to go to work. You're supposed to come to work for 14 days. And then during that 14 days, you still monitor symptoms and follow IPC precautions. Should you develop any symptoms, then you are eligible for testing. Yes. So now, after testing positive, say in OPD and in theater, usually your colleagues be worried and saying, hey, we need to clean the area, hey, close theaters, hey, close OPDs and all those things. There are also guidelines that we need to follow, okay? We know that the longest survival COVID on surface, it's said to be 6 days, and that was a study done by Lancet in 2020. And then with experimental cases, the coronavirus disease has been detected on surface for up to 72 hours, meaning that after 72 hours, there is no evidence of coronavirus on surface. Healthcare facilities need to be cleaned twice. Those are non-COVID areas. But areas such as high-risk areas, which are COVID areas, areas like COVID triage areas, your testing areas, isolation ward, ICU settings, the guidelines say they need to be cleaned 3 to 5 times. It is our prerogative as healthcare workers to ensure that these processes happen. Otherwise, if they do not happen, it's us who work in those kind of environment who will get reinfections. You know? So decontamination procedure. To decontaminate, it means an area has to be contaminated before. So contamination is defined, or a contaminated area is defined as an immediate area and or ablution used by a staff member who tested positive. It could be the wards, it could be ICU, it could be theaters, it could be offices or even bathrooms. So what does decontamination entail? So decontamination basically includes some or of all of the following steps: deep cleaning, disinfection, or sterilization of such area. Usually this area are cleaned after a positive case, like I said, or after following a discharge of a COVID patient in isolation ward. That area or that end suite has to be cleaned, or that cohort area of isolation has to be cleaned. Or a case of a patient who was in casualties before being transferred to COVID ward, later on the results come back positive, that area has to be cleaned, as long as it's done within 72 hours. If it's done after 72 hours, it's a futile exercise because there is no coronavirus disease on the surface. The process itself, it involves deep cleaning, meaning that you clean everything, the walls, the floor, the rails, the bed rails, and then the medicine trolleys and everything. Like I said, it has to be within 72 hours. After 72 hours, it's a futile exercise because the virus is already dead. Environmental health will help you. They use either alcohol-based substances, or they will use biocides to clean the area. These substances that I'm mentioning, they're said to be safe for reuse within 30 minutes. So if you clean an area with alcohol base, 70% or more, you can use that area within 30 minutes. There's no that thing of closing the area for 3 days or 8 days. And then I must say, I just put this picture here deliberately. It's been said, according to IPC regulation and WHO, that spraying, fumigation or fogging, it has no value. It has shown that it has plays no role, and it has no benefit in decontaminating the area. Rather, expose healthcare workers to adverse effects side effects, and it can miss areas that need to be cleaned quite effectively. So hand cleaning with those detergents, it's what is recommended according to the guidelines. In summary, principles of management of COVID exposure in healthcare workplaces will include improving in-personal health procedures by prompting counseling and support for care workers. It will also include public health communicable disease procedures. So we need to follow NICD reporting, notification, and contact tracing to cap the spread of the disease. Follow infection prevention and control procedures by implementing our protocols at workplace, SOPs, and all those kind of things. Also, it includes principles of occupational health and safety procedures. This is usually assessed on a risk, based on a risk assessment, cleaning and decontamination, like I've just alluded just now. Engage on labor relation procedures. The management and organized labor should come into play and cooperate, work with us cooperatively to address these issues. Incident reporting, engagement with relevant regulators is very important, like I've alluded initially. Compensation, you can be compensated as a TUI, or whether it's a consent case, or if death ensued, you can also be compensated. Leave and workmen's compensation arrangements has to be followed according to Basic Condition of Employment Act of 1997. Colleagues, in conclusion, this pandemic will pass, but it is up to us how long it will stay. President Cyril Ramaphosa. Apart from the direct infection risk arising from close contact with patients and or potentially infectious co-workers during the COVID-19 pandemic, us as healthcare workers we are under increasing stress and mental health risk. There's so much we can learn. I thank you.
Yes, thank you very much, Dr. Segule. When we started, we had a number of technical glitches, but I'm quite happy to see that we've managed, to get a walk around it. So colleagues, thank you very much again for attending. I would like to take any questions and discussions, but before that, I want to check if Dr. Zwane is in the call. Dr. Zwane, are you in the call? I would like you to make inputs from your experience working with healthcare workers, if you are around.
Thank you very much, Dr. Mawela.
Yes, Dr. Zwane, you may make your comment.
All right, thank you very much. So the comment that I would like to make is in terms of compensation. I think that most healthcare workers they get worried as to is there a compensation and how do they go about it? Can you hear me?
Yes, we can hear you now.
All right, thank you very much. So in terms of compensation, what happens is the guidelines that are being followed currently is the 1993 Compensation Act for any occupational compensation, be it COVID, be it anything else. But in this context, we're talking about COVID. So first and foremost, the first thing that needs to be confirmed is that it's an occupationally acquired COVID-19. So there has to be proof of occupational exposure to a known source. By that, I mean the patient's results needs to be submitted. Secondly, we need the occupational health doctors are going to need a reliable diagnosis of COVID-19. So meaning basically that as the healthcare worker who has been exposed, you need to provide proof, laboratory proof of your results that yes, you do have COVID-19. Thirdly, there has to be a chronological sequence between the source and the development of symptoms, meaning the time you're exposed to the source and also from the time you started having symptoms. Fourthly, there has to be a medical report. From the medical reports, there has to be the first report, the progress report, and lastly, the final report. I saw there was one of the questions where on the chat where someone was asking as to, are these the same procedures that the steps I just mentioned, or the steps that Dr. Scully just mentioned, can one follow them if they also tested privately? And fortunately, yes. Even if you tested privately, you're going to need all the things that I'm mentioning and what Dr. Scully has been mentioning. But as for the reports, since you've tested privately, it means you're going to need a first report, a progress report, as well as a final report from a private practitioner. So the mistake that most of us healthcare workers tend to make is that we then present with the results, but there is no doctor's report. And for compensation, that report is needed. In the report, it needs to be clearly outlined as to what symptoms the person experienced, the laboratory results, as I've already mentioned, and also radiological evidence or radiological report, if there is one. So that was the fourth thing, the medical report. Lastly, you're going to need to submit a certified copy of your identity document, and also you are going to need a payslip, right? So, and then finally, you are going to fill a compensation form. Once all of these documents have been completed, you're going to submit them to labor relations. Or if you're already being seen at the hospital, you can submit them to occupational health, who's going to submit them to the labor relations. Every hospital has got a department of labor. So that's where the documents are submitted, and you can follow up with them maybe on a weekly basis. Lastly, Dr. Mawela, allow me to say that the benefits offered for this compensation, it includes 1, days of absenteeism, because following whether you are a POI, or rather, let me talk about a confirmed case, because compensation mainly talks to the confirmed cases. The days that you're going to be absent, these days should not be taken from your sick leave. These are basically, it's an occupational exposed disease, so these days are not going to be subtracted from your annual 22 days of sick leave. And then the compensation fund that it's actually compensated for, it includes one of 4 things. It's either a temporary total disability, meaning you've been for the period that you've been ill, this is within 30 days, or if you have you now have complications from the disease, like maybe chronic respiratory problems following COVID, there's a permanent fund that you should be given. And then thirdly, a medical aid to pay up for the expenses that you're going to go through during the period when you are ill. And lastly, let's say, God forbid, it's a death benefit that is also included on the compensation funds. Thank you very much.
Yeah, that was quite informative, even for me. I don't think the issues you have just addressed now, Dr. Zwane, are things that most of us, are familiar with. And thank you very much for highlighting that. Colleagues, it's your time. If you have any questions, comments that you would like to make. We know that it's a challenging time. Most of us are either exposed or even infected, and as cases, we have our experiences. If you would like to ask specific questions, do raise your hand or even unmute your mic so that you can get a chance to comment on this important topic. Do we have any hands, any comments? Yes, Sister Masemola. I'm hoping, it's a sister, but I'm hoping you're the one I'm thinking about. Yes, you may comment, ma'am. Thank you.
Yes, thank you very much for the occupational health in relation to COVID. It was quite interesting as one of the occupational health nurses who have worked so much for the rest of my life in the companies with occupational health. I'm happy that this is now taken so seriously in the public health sector. I've just joined you very late. How can I access the presentation?
Okay, thank you. So we will share the recording. We will make the recording to be available. Yeah, so we will make the recording available. And the presentation, if you go to the chat box of this Zoom meeting, you should be able to find a PDF and document which has been shared, which yeah, and I think you'll be helped in that way. We have Dr. Titi Bohoshi. Ms. Masemola, are you done? Yes, okay. Dr. Bohoshi, thank you.
Hello. Thank you very much for giving me this opportunity to talk. That was very well put out, Dr. Squad. But I do have a question of my own. I'm not sure if we are already open for questions.
Yes, you may ask your question.
Okay. I would like to know what is the procedure, or how does one go about if someone who is not a healthcare worker, like maybe a spouse at home who is to maybe be exposed because of being in contact with maybe someone like me who is a healthcare worker, where exactly do you advise for them to get tested, in a private facility, or where exactly?
So is your question about the testing of the spouse or of the health worker who's exposed to a spouse?
For the spouse who is exposed, let's say that for many of us who are working in the health department, we are exposed day to day. But then if maybe I was to test positive, how would I go about advising my partner or my children who are exposed to go about testing?
Okay, no, I think that's a valid question. So how do we manage contacts of healthcare workers? Yes, Dr. Segolo, you may go for it. Yes. Dr. Segolo, you may go for the question. How do you manage contacts of healthcare workers?
Thank you. I think the question Dr. Bokhoshi has asked, it sounds like it's got two folds. If I understand him very well, the first question is, if you are a healthcare worker, staying with somebody who's not a healthcare worker, and then that somebody tests positive and get you exposed, where do you go and test? And the second part of it, I think he says, if you are a healthcare worker, you test positive, how do you go about dealing with at home, telling your spouse and families and isolation and quarantine procedures? Is that correct, Dr. Bokhoshi?
Yes, that's correct.
All right. Yeah, so with a healthcare worker that get to be, according to occupational health guidelines, I know Dr. Zwan is here, will help me as well. As far as I'm concerned, if you get to be a contact from a non-healthcare worker,
can I ask a question, please? Hello, colleague, can I ask a question? Yeah. Hello? So 2 minutes, please. Hello?
Continue on that question.
all right, colleagues. I was saying, I don't know if you heard me, the initial one. If you are a healthcare worker and you get exposed at home by a spouse who's not a healthcare worker, Usually that is regarded as exposure in social circumstances, and then you may have to go and test privately. But the isolation and the quarantine procedures will follow as discussed. The only issue that may preclude or may not be necessitate is the issue of compensation. Hence, every case gets to be reported at MICD. When it gets to MICD, it gets to be reviewed whether the contamination was due to negligence or social circumstances, or was at workplace, so that people can be compensated accordingly. In terms of a healthcare worker who tests positive and has to go home to families and all that, I think that topic will be covered clearly next week. We've got a panel of healthcare workers who were infected and have recovered. So we have a panel discussion. Maybe they can enlighten us as how they dealt with it in terms of informing the family, psychological issues, isolation, quarantine, and all those kind of things. Thank you.
Yes, thank you very much, Dr. Segule. Dr. Zwane, is it something you want to add to this question?
Thank you, Dr. Mawela. No, I'm happy with Dr. Segule's answer. Dr. Mawela?
Yes, I'm asking, is it something you want to add to?
No, I think I'm happy. He covered it very well. Because in terms of the second question, when Dr. Bokoshi was asking what happens now with the family. Yes, we are going to cover it next week in the panel, but so far I haven't come across guidelines which actually says that the family can be taken for testing at our hospital. For example, like me, I'm working at Witbank Hospital. I haven't come across guidelines saying that they are now covered under the occupational, like in the occupational services. So what has been happening currently is that if one tests positive, the family now has to test privately. That's what I've noticed. And I've also went through the same situation as well. That's why I'm saying we'll cover it next week. But so far, from most people that I've came across, the family members who were exposed to someone who tested positive, who happened to be a healthcare worker, they have been testing privately, because that is not occupational exposure. It also falls under the social exposure. It's like, because I can see but it's anecdotal evidence. This is just my thinking that if family members were to also be tested under occupational because they've been exposed by the spouse, it would then mean even church members, for example, or everyone who's been exposed to the healthcare worker will now need to come for testing at the hospital because they've been tested there. I don't know if I'm explaining it in a way that is clear. But in summary, from the experiences that I've seen, most family members end up testing privately. They are not accommodated under the occupational healthcare services. Thank you, Dr. Mawela. Hello?
Hello.
We can hear you, yes?
Yes. You have said about the 10 days and 14 days post for the isolation and coming back to work. But yes, occasionally you find that some of the symptoms, or signs or difficulties of these patients have not cleared after that period. You find the patient is actually still with a bit of difficulty, although the days have passed. In that situation, and if you extend the leave, will it be still covered, or will it be an ordinary sick leave? What would be your comment in that situation? My second question really for discussion would be, in a situation where a health worker is faced with management of a COVID patient situation, but the appropriate PPE is not existing or is inadequate. What would be the comment of, what would be the, of course, with our ethics, especially doctors and so on, one would want to save, but the question is, would you want to save your life before you save the other patient? What would be the comment?
Yes. I think Dr. Segule has hit you. So patients who are still symptomatic, Dr. Segule, after 10 days,
what then happens, and then what the implications on their sick leave. Maybe Dr. Zwane might add to that. And then the issue of PPE is not available, but you have a PUI who needs to be tested. Yes, Dr. Zgole?
Okay, I think I'll start with the second one. Thank you again, Chair. The second one is easy. Colleagues, let's not put our lives at risk. No PPE, no work. Okay, thank you. All right. Then regarding the first one, healthcare work, I think it's a point that I had missed, I should have made in the occupational health. It's regarding a healthcare worker, when they return back to work after 10 days of de-isolation, they get to be re-examined again by a doctor, an occupational health or a nurse. If they are deemed not to be fit for work, and their leave get to be extended. But if they are fit to work, they go back to work. So now their leave will be extended.
All right. Yeah. So yeah. And then you must remember that also on that protocol for de-isolation, if it's a symptomatic patient, you would count from the time when they become asymptomatic. So
yes,
we don't expect 10 days to lapse whilst they are still symptomatic. So it's very important that for the asymptomatic patients, you count 10 days based on the results. For the symptomatic patients, you count 10 days from the time when you reached clinical stability or they became asymptomatic. Yes. Naledi, do you want to unmute and ask your question?
Yes. Can everybody hear me?
Yes, we can hear you. Thank you.
Okay, thank you. I would like to ask a question to Dr. Zgole, and maybe Dr. Zwane or anybody who has sort of input to my question. My question is, I'm working at Witbank Hospital. It's a problem that's not only unique to my hospital, but we're seeing a rise in, healthcare workers who are and are ill, and some are even to find out just from the experts. What do you think that, I know one of the issues is that there is no PPE, but that there is not enough training to use the PPE correctly, or maybe just a combination of multiple factors. Yeah.
Yeah. No, thanks, Naledi, for your question. Unfortunately, your line is not clear, but my understanding of the question is that you are saying you are seeing a lot of healthcare workers becoming infected or becoming sick, and we are also losing life, and you want to understand whether, in addition to whether PPE is adequate or not, are there any other factors driving health workers to become infected? Yes, Dr. Zgole?
All right. Thank you, Dr. Mudiri, for the question. Once again, colleagues, being infected or exposed as a healthcare worker, to me, it's multifactorial. You need to ask yourself, where, before being a healthcare worker, where as a person can you be infected? So it's either at the work environment or non-work environment. And that's something that we need we play a blind eye on it, especially the non-working environment. Issues of social gathering, funerals, weddings, that's where most people get infected, But in terms of being infected at work environment, issues that were picked up is that there was in most hospitals, there is no adequate training. These were picked up when I was giving my first talk for the province about hospital readiness. Training, more especially about donning and doffing. Donning and doffing is not like wearing in theater and taking off, especially the doffing part. That's why most healthcare professionals get infected. Adequate training, Dr. Mawela, we need to re-emphasize on this in our district hospitals and the province as a whole, especially on the doffing part of it. So most people get infected during the doffing. So sometimes it's not just mere lack of PPEs, but it's how you take them off. After testing a patient or working in a COVID ward, you can be infected. The training about testing as well, the technique that you use, wearing a proper PPE during that testing, it plays a very important role. It's one of the areas that has been highlighted that most healthcare workers get infected. The issues that I've highlighted about the cleaning of the environment, decontamination procedures. It's not every hospital that do decontamination procedures. Guys, we need to be adherent to these regulations. And it's our prerogative, it's upon us as healthcare workers to make sure that this system and this thing happens. You can't have a situation where a patient tests positive in casualties, and then the result comes within 72 hours. The area is not decontaminated, and then you're expected to go back and work in that area. It's our prerogative to make sure that these processes are followed up, and that's why you get reinfection, and we wonder why colleagues are getting infected at high rate. Lastly is the PPEs. Yes, it could be because of lack of PPE, but I don't think there's anyone who can work without a mask or gloves nowadays. So now it has to do with the use of the PPE. Are we taking off the PPEs correctly? Are we using correct PPEs for right reasons? You know, in one of the situations where I had to address certain individuals in a certain hospital, one colleague of ours was wearing a cloth mask in a hospital setting. That really upset me. We can't afford to have that kind of situation. In a hospital setting, you wear surgical masks. So we need to improve in training and educating. We've got flow charts and recommendations that we have made for the district that we can share with other hospitals on recommended PPEs. You cannot find yourself in an isolation ward or a COVID ward not wearing your coverall. You get what I mean? If you don't have, don't, because you're going to get infected as a healthcare. And we'll see a rise and increasing number of those. You know, other than that, we still need to adhere to IPC protocols. I don't know who said as healthcare professionals were immune. We know it, guys. We still need to social distance, wear mask, and hand sanitize. So in a nutshell, Dr. Mudiri, it's a bit difficult to pinpoint what exactly is making a rise in increasing of number of healthcare workers infected. But my advice is that within ourselves, within our working environment, let's do what we can do. When you get infected, let it be under extreme situations where you have done everything you could.
Yeah.
Thank you.
Yeah. No, thanks, Dr. Asegole. May you kindly address the issue of fuming and fogging? I just saw a comment saying Dr. Asegole replied to that. Thank you.
Okay, yeah, previously then, with this disease, we learn every day, and the studies that are done almost every day, and updates. That's another thing. As colleagues, let's learn to read those updates and understand these diseases. Previously, you see people spraying, fogging, and fumigating. I mean, studies have shown from IPC regulations, guidelines, and WHO, and some other European studies that spraying and fogging and fumigation is not recommended. For the very simple reason, it is found to be ineffective. It doesn't kill the virus, doesn't do anything. And then you may miss areas that you need to deep clean, especially the corners, you know, under the beds and all those areas if you're not using hands, you know. And then worse, it comes with side effects and adverse effects to healthcare workers, especially with the substances that they use. So they recommend that we use deep cleaning with detergent and avoid spraying. I know other centers in Europe, they use ultraviolet radiation, which is called zapping. I'm not well versed with that. That's something that we can look into. But fogging and fumigation is being discouraged as it's not recommended.
Yeah. No, thank you very much, Dr. Segole, Dr. Zwane, the Wheatbank team, Nkangala, and all people who have attended. I hope that this session was really worth your time. We are 10 minutes behind time. I'm just going to ask Mr. Letlalo, just to say closing remarks on this issue, summarizing some of the issues that were discussed and raised. We will make the video to be available for viewing, and thank you very much for your time. Maybe Mr. Letlalo, before you make your closing remarks, Mr. Tsebe, sorry, Audrey Tsebe, yes, can you make your comments so that we can close?
Let's always like the follow some next week.
Aubrey? Oh, okay. No, yes. Mr. Letlalo, you may close the meeting for us. Thank you.
Thank you very much. Can you hear me?
Yes, we can hear you.
Yeah. Thank you very much, colleagues, for this presentation. Thank you, Dr. Mawela, for leading the discussion. But also, thank you for the presentation. I think it will assist
Colleagues,
us.
may we mute our mics? Colleagues, may we mute our mics, please?
Yeah. Hello.
Yes, continue, Mr. Letswalo. I will mute them. Thanks.
Yeah. No, I was saying thank you very much. I think it will demystify the COVID-19 and the treatment that we have to do, especially as healthcare workers. You know, when you go around and see the integration of people who are coming from isolation or quarantine, it also affects them psychologically. So I think as we continue with this presentation, this will ultimately help us as to how do we really approach this. And thank you very much. I believe that this is one of the discussions which will ultimately take our district, and to those who are joining, I saw that there are those who are not necessarily from our district, but everyone who came in. Thank you very much. Let's go and practice what we have learned today, and it will assist us a lot as the community of healthcare workers. We need each other now at the peak, and we will need each other post the peak. Thank you very much, Dr. Moy.
Thank you. Thank you very much, Mr. Letlalo. Colleagues, just to say that next week we have a panel of health workers who have been exposed, affected, or even infected, and they have, survived the virus. Please join us as we have this panel of health workers sharing with us their experiences, their challenges, how were they isolated and how do they believe they actually became, affected, exposed, or infected. So I believe that it's going to be a very dynamic session, mainly to empower you, but to ensure that we are able to learn from our colleagues. Thank you very much, colleagues. Looking forward to see you again next week. Thank you. Bye.
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 Bye-bye.
Bye.
Hey. What a roller coaster this one. Hey. Technology got you going to replicate this. Did you?
I don't know what happened.
Yeah, no, it's okay. But
I must just check. I was just buying a new laptop. And after work, I can't really check first.
yeah. But none of us are wood.
I just get to check my name for information.
Yeah. We will hear from there. It's like a test. That's why they were able to comment. Yeah.
To comment. Yeah, but the good one, well done, my guy. The first of
Hey.
You must archive this one.
Yeah, 40 something. You did well. Because
but otherwise, I think we covered most of the things. If we listen to the Azumur,
yeah, that's the issue. That's the issue. Ntwana na attendile mo. Ntwana uti pizza mang Beni. Ke na Beni or ke Monju? Monju.
Yeah, I can after next week physical challenges with COVID.
Hey, yeah, they are.